Good afternoon.
Good afternoon, everybody.
Good afternoon, good afternoon, good afternoon.
Hello.
Good afternoon, Dr. Sanjay.
Hi.
Hi.
How are you? How are
I'm
you?
very good, thanks. How are you?
Time, a little before time only. Is Bangalore very warm?
It's warmer than usual, but
Uh-huh.
yesterday I had to be in Calcutta. That was
Okay.
terrible.
Calcutta can be terrible at this time.
Oh,
Yeah.
horrible,
You're
yes.
still in Calcutta?
No, I got back yesterday night, last night. So, yeah.
Hi, Josna.
Hi.
Hi,
Hi.
Ma.
So,
Where you're on, have you put your video on?
yeah,
Okay.
me? Hi, Dr.
Hi, Ma.
Dr. Manish Kumar, who has joined us also.
Acha,
Okay.
okay.
Good afternoon, everyone.
Hi, Aruna.
Aruna, good afternoon.
Good afternoon, ma'am.
Hello.
Good afternoon, ma'am.
Good afternoon.
So, Dr. Sanjay, we again pulled you out. Lovely,
Wow.
nice.
Rashmi Vora is there, Sanjay.
Hi, yeah, I'm there. Yes.
Hi.
I'm not able to connect because this girl wanted the money, the cleaning lady, so I just sorted it out. Yeah.
Good attendance of FDP.
That's
Yeah.
right.
Very encouraging. Good.
Is Renu there?
Renu, I don't
We'll
see.
have to see the code.
There's a message from her.
Mhm.
It says, sorry, cannot join the webinar as there's no electricity here. Mobile also needs charging. So we won't wait for her. I think, Indra, if you will please
Oh, God.
welcome Sanjay.
Only
would
thing
like
is
them
that
to do the honors. I only can say that, it's so nice to have Dr. Govil again with us. And the way he makes the subject so very interesting. I think you can already see how many people are there. And I'm sure we are going to get a few more also. Thank you so much, Sanjay, for sparing your time. I only have, you don't have any surgeries today. So, you're not wasting your time with us. Thank you so much.
okay. Dr. Sanjay, at the outset, I must thank you for taking time out of your busy schedule once again to educate us on the remaining 3 GI cancers. And if you correct me, probably we'll take it as their location in the digestive system, esophagus, then stomach, and then colon. Is that right?
That's right. Yes.
Okay. So I'll probably will ask him some questions soon after he finishes one cancer.
Yeah.
Thank you. On to you, Dr. Sanjay. There's
Thank
no
you.
formal introduction
No,
today.
no, not necessary. Thank you. I'll just share my screen and is that okay? Can everybody see?
Yes.
Yeah.
Please mute yourself, everyone.
Yes, sir.
So good afternoon, everyone, and thank you once again for this opportunity. So before I start, I have one important disclaimer, and that is that although I'm a GI surgeon, I have not been dealing primarily with esophageal, stomach, and colorectal cancers because for quite a long while. I mean, probably a couple of decades. So, if you ask me very tough questions, I'm going to have to look it up probably to be sure. But some of the common things I do know and have just made these slides for. So we'll start with esophageal cancer. So esophageal cancer is a quite a deadly cancer, but the hallmark symptom is difficulty in swallowing or food getting stuck when you try to swallow. And by the time you get this symptom, approximately at least 2/3 to 70% of the circumference of the esophagus has been involved by the tumor to block it. And treatment is nowadays, with all these, is some combination of chemotherapy, surgery, and radiation. But we're discussing the predisposing factors. One of the important ones is gastroesophageal reflux disease. Now, this is a difficult situation because this is such a common disease that they say that at least in the US, nearly, if you just ask for symptoms of reflux, nearly 50% of the population has some or other symptom of reflux. And if you're looking at if you're going to define it by doing an endoscopy and looking for some inflammation, because you can get the symptoms without any changes on endoscopy. So the symptoms are actually what initiate treatment for this for gastroesophageal reflux disease. But if you look for symptoms and you define it, I mean, if you look for ulceration or inflammation of the esophagus as being features of gastroesophageal reflux disease, you're still looking at around 15-20% of the population at least. So it's a very, very common disease. And what makes it even more complicated is that you can have inflammation and be completely asymptomatic as well. So you get this whole spectrum of patients with symptoms, patients without symptoms, patients with inflammation. And so to define which of these is going to go on to develop cancer is very, very difficult. And it's important to remember that only a tiny, tiny minority of the patients with reflux disease will develop cancer. All we know is that patients who have more intense symptoms over a period of more than 20 years and very frequent, almost daily symptoms or after every meal, then those are the patients who have a slightly higher predisposition to developing cancer. But again, it's a tiny minority. The risk increases in patients with GRD about 5 times. But if you look at all the patients who've got gastroesophageal reflux disease, of which I could find only one study, the risk of developing population-based study out of those who will develop cancer, it is as tiny as the figure I put on my slide. It is 0.00065 per patient with GRD will develop. So you have to have, what is that? 1, 2, 3, 4, 5. So 1 lakh patients with GRD, and you might get less than one, or you'll get about 5 or 6 patients with cancer in 1 lakh patients with GRD. So there is, because the frequency is so low, there is obviously no clear-cut recommendation for screening patients with GRD. And it would be, first of all, if you try to do that, it would inundate medical services because you'd require so many people to have endoscopy. And the yield from it would be so low that it's economically not viable to perform this kind of screening. So now there is why you get GERD, you can get it, anybody can get it even with normal anatomy, but people who are very overweight, people who have got hiatus hernias, these are patients who have a slightly higher risk of getting GERD. Hiatus hernia by itself does not increase the risk of cancer, but it increases the risk of GERD and therefore developing potentially developing cancer, but a very tiny a number of patients. Barrett's esophagus is also a variant of, is a subset of patients who have GERD. And what happens here is that the esophagus is lined by what we call squamous cell epithelium. That is very much like the skin, except that the skin is keratinized. So very much like the inside of your mouth is the lining of the esophagus. And then when you go into the stomach at the gastroesophageal junction, the lining cells change. And from becoming these protective cells like they are of the skin, multiple layers of cells, they become a single layer of cells which produce mucus and have enzyme-producing cells and so on. So you have a sharp transition normally between the esophageal lining and the stomach lining at the gastroesophageal junction. But in about 5 to 15% of patients with reflux disease, what happens is that as the ulceration occurs in the lower end of the esophagus, instead of being replaced by the squamous epithelium, which is the normal when it heals, instead of healing with from the esophageal side, it heals from the stomach side. Now, this is not strictly speaking true, but basically what happens is that the stomach epithelium which sort of creeps into the lower end of the esophagus. And this is called Barrett's esophagus. Now, again, what proportion of these patients, definitely there is a higher risk of cancer in such patients. And the risk has been estimated as being anywhere between 40 and 125 times. It's a 0.005 annual risk. So we're still looking at a very small proportion of patients. And patients here who develop, if you biopsy this stomach epithelium, if you biopsy it and it shows dysplasia, which is again, an abnormal form of mucosa, then that means that these patients have a higher risk of developing the cancer. And if they have high-grade dysplasia, there are recommendations about potentially considering surgery or at least very close surveillance. Once again, there's no internationally recognized standard for screening endoscopy because, again, the risk is small and people aren't sure whether you should be screening everyone who's got even a little bit of a Barrett's or you should be looking at what we call long segment Barrett's only. But each center has its own sort of screening protocol, especially to select and follow up the high-risk patients. So anybody who has any form of dysplasia on biopsy will need to be closely followed up. And just to show you the different types, what it looks like, this one here is the normal esophagus, and that's where it just enters the stomach there. It's just about to enter the stomach. This one here, you can see that there are these ulcers and inflammation in the lower end of the esophagus, just at the junction with the stomach. And this is quite severe GERD. Oops, sorry. And here, this is Barrett's esophagus, a short segment Barrett's, where the lining so you can see the paler mucosa of the esophagus, and then this is the mucosa from the stomach, which has got intestinal cells, so goblet cells and cells which produce mucus and enzymes and all that, which is growing out over here. This is a very short segment of Barrett's, but you can have this extending almost in some patients, extending all the way up to the middle of the esophagus, in some patients, and they would obviously be at an increased risk compared to a patient like this who has a very short segment of Barrett's esophagus. And then finally, it may turn into a cancer where you get this nodular ulcerated lesion on the inside of the esophagus.
Excuse me, you use the word dysplasia. What does actually that mean?
So, you know that you have the normal cells and the normal cell structure as there is a process of that turning into cancer, where in cancer, the cells are completely misshapen, disorganized. And the relationship between the shape of each cell and the relationship between the size of the nucleus and the cell will all be completely altered. So this is a sort of a process. And dysplasia is as the appearance of the cell, appearance of the cells in that biopsy as they become more and more abnormal. So cancer is one extreme, the normal is the other extreme, and then you have low-grade, intermediate-grade, and high-grade dysplasia in between. So once you develop dysplasia, it means that you're on the track towards moving towards a cancer. You've taken that first sort of step. And that's why these patients need very close surveillance. And some people may choose or be advised to have a surgery or to remove the esophagus. More often, what they try to do is that they try to burn off the area of diseased esophageal lining and hope that it will be replaced by the healthy normal lining, but that doesn't always happen. So it's quite a tricky decision as to how to proceed in such patients and how often to follow them up. And once you get high-grade dysplasia, you have to be very, very careful, because once it moves into a cancer, then you're already in trouble. Okay. A few more things for esophagus. One is a condition which is called achalasia cardia. I don't know if you can see this X-ray here, but this is a barium swallow in which the patient has had barium, and you can see it's a very dilated, tortuous looking esophagus. And then it comes to a sort of a point at the lower end of the esophagus just before it joins the stomach. And this is a condition in which the patient does not have any nerve cells at that point where the narrowing is. So the muscle contractions cannot be transmitted. It starts from the top of the esophagus, but it can't be transmitted across that short length at the lowermost end. And so what ends up happening is that it's almost like an obstruction, but it's not actually an obstruction. It's just that the peristalsis, normal peristalsis, which is the movement of the bowel, the contractions of the bowel, cannot be transmitted across that segment. And for that segment, then the only way for it to empty is by gravity. The pressure keeps building up, the weight of what you've eaten or drunk increases in the esophagus, and then it sort of pushes its way through that narrowed area. And the treatment for this is either to put in a balloon and stretch the narrowed area so that you split the muscle and then just allow everything to pass through across it, or you surgically split the muscle of the esophagus in that area so that the food is able to go down. Now, this obviously increases the risk of any of these procedures, increase the risk of reflux because you've destroyed the lower end sphincter there. And nowadays, all this can be done endoscopically. So the role of surgery has become very less. These patients are at risk for, especially older patients who have this, are at risk for developing a cancer. And it usually occurs in the dilated segment higher up because that's where all the inflammation occurs because of the collected food, and swallowed material. And that's where the inflammation happens. So it's usually in the more proximal part of the esophagus where they get their cancers. Again, there's no recommendation for surveillance in such patients. And nobody has ever shown that by undergoing surgery for this or undergoing balloon dilatation or endoscopic treatment that it actually reduces the risk of cancer, because you're reducing the difficulty in swallowing in these patients, but you're also increasing the chance of reflux. So it's difficult to conclude, that treatment will help these patients from the point of view of reducing their cancer risk. It might a little bit. The other is esophageal strictures, which are usually long narrowings of the esophagus. Most commonly, it is caused by either an accidental or suicidal attempt at drinking either lye or acid. In our country, it's a lot easier to get acid. So most of the esophageal injuries in our country don't occur from lye, but from acid. And typically, this can severely damage the lining of the esophagus. And it can get past the lining of the esophagus and enter the stomach, where it causes spasm of the outlet of the stomach and the acid collects inside the stomach. So you can get huge ulcers in the esophagus as well as in the distal part, the last part of the stomach near the outflow. And when these ulcers heal, they form bad scars, like burn scars inside the food pipe and the stomach. And these also increase the risk of developing cancer, or 2 to 3 times in these areas. There are a few other rare situations. Plummer-Vinson syndrome, I don't think I have ever seen one in my life. It's something that occurs or used to occur in middle-aged women who develop severe anemia, and they develop an esophageal web in the upper part of the esophagus, just below just where the esophagus starts. And again, these patients, 1 in 10 of them were supposed to develop cancer. I don't know whether it's just of historical value, really. I've never seen it. Tylosis is a skin disease in which you get very thickening, severe thickening of the skin, especially on the palms and the soles of the feet. And because the inner lining of the esophagus is very much like the skin, it also affects the inner lining of the esophagus, where you get this real thickening of the lining, and some of these can go on to develop cancer. Again, I have never seen anything like that. And I put in human papilloma virus because I think, now there's this whole thing of immunization against it. So in India, people, or not India, but in Asia, I don't know what the incidence of this is in India, but in Asia, especially in China, they found that nearly 50% of the people who develop squamous carcinoma of the esophagus will also have human papilloma virus, or one or the other of the human papilloma viruses. So again, it's unclear, although it's prevalent, it's unclear as to how important it is in the development of esophageal cancer. There is some literature to suggest that maybe patients who have the human papilloma virus type of esophageal cancer may have a slightly more indolent cancer, but this is not universally accepted. And the role of immunization to prevent this cancer, it's too early to say whether this is going to make any difference at all, because immunization is not universal. And in any case, it's only come on quite recently. So if it's going to make a difference, we'll have to wait and see for the next 10 or 20 years whether there's going to be any difference from the papilloma virus, from immunization. So I think that's all about esophagus. And if you'd like to ask anything before I go on to stomach, please.
Okay, just one or two, because you have whatever I had written, you had answered a few. You talked about hiatus hernia or hiatus hernia. So there normally the findings by the endoscopic screening, their symptoms are the same of the esophageal cancer and hiatus hernia, the reflux and all, and also the endoscopic screening method is use of endoscopy. So what are the difference then, in the endoscopic findings of say hiatus hernia?
So the thing is, the symptoms are not really the same in that although there can be an overlap, hiatus hernia usually is associated with, I mean, you don't really get any what we call dysphagia. You don't often get a block when you swallow, a sensation of food getting stuck when you swallow. You can have symptoms of reflux, which is the most common symptom associated with a hiatus hernia. And sometimes you will have some degree of pain or discomfort, but usually not a blockage to the swallowing of food. So
yes, probably they feel a bit of choking while eating or something.
So that is usually the choking sensation that you get with a hiatus hernia is actually referred to the neck, high up in the neck. Strangely enough, I'm not sure of the reason, but people who, even though the inflammation is at the lower end of the esophagus, they usually feel the symptom up in the top part of the, in the upper part of the neck. So, whereas most cancers, when they cause a blockage, because most of these cancers are in the middle or lower part of the esophagus, the sensation is usually localized further down. So that's one difference in terms of symptoms. But yeah, the screening in these, meaning that if you have a doubt about the diagnosis, the best way to make the diagnosis is with an endoscopy. And then
probably biopsy of.
Then if there's a suspicious area, when you have a look on endoscopy, you biopsy that. But remember, hiatus hernia is actually the stomach coming into the chest. So, your
diaphragm,
basically at the esophagus, which is
right. Thank you.
Can I ask a question, please?
Yeah,
please do.
Yeah. Sanjay, in Atul Gawande's books, he writes about the elderly in whom the angle of the mouth and esophagus changes, and that elderly people are more likely to choke on their food unless they're careful. Is that correct?
Yeah, I think it is correct. I mean, I'm not, I don't know, I haven't read, I can't remember that part of what he's written, but it is true that they're at a higher risk of aspirating their food because there is I don't know whether it's because of a change of angle, but there is also, just like you have achalasia cardia, where you have the narrowing, the transmission of the contractions doesn't go through that lowermost segment. You also have something called presby esophagus, Presby, in which occurs in older people, in which the contractions of the esophagus are also very discoordinate. So it's not like the snake moving, you know, and propelling the food down. It's just a discoordinate contraction at all times. So you may not coordinate your, your swallowing may not be as coordinated as it would have been when you were younger. And there is a slight risk, increased risk of aspiration of contents into the esophagus. Maybe there is some change in angle. I'm not aware of that, but certainly this is one potential cause.
Thank you.
Yeah.
Back to Aruna.
I don't have any more. You talked about Barrett's esophagus, which I was going to ask, so that's okay.
Yeah.
Thank you.
Okay, shall I go on to stomach?
Yes, please.
Yeah. Yeah. So, stomach cancer is quite common in our country, one of the more common cancers. Number of potential causes, one of them being this bacteria called Helicobacter pylori or H. pylori, which many of you may have heard of. The founder of this bacteria was an Australian gastroenterologist who got the Nobel Prize for discovering it, because by discovering it, he found that almost all duodenal ulcers and many gastric ulcers are caused by this infection, and therefore, all these drugs like well, certainly surgery for peptic ulcer disease has become almost obsolete nowadays. The drugs that were used like cimetidine, ranitidine, and all the PPIs, although we use them more for inflammation and reflux symptoms, it's not all that common as it used to be to have peptic ulcers. But there is an association, and again, it's a it's something like GAD, where Helicobacter is known to be associated with gastric cancer, and especially a type of gastric cancer, which is a lymphoma, a malt lymphoma, it's called MALT lymphoma, but also regular gastric cancer. Now, they say you treat it with triple therapy, that is 3 antibiotics, which you take over 2 weeks. But in a country like India, the likelihood that you're going to get reinfected with Helicobacter pylori is almost inevitable. So there's really not much point in going on taking treatment for Helicobacter pylori, because there's no end to it. And again, the proportion of patients who are going to get a cancer is minuscule. I couldn't actually find what minuscule proportion, but it is an association, and I don't think anyone should worry too much about whether you get it, because we almost all inevitably have it. Now, in fact, of all the various non-hereditary causes, one of the common things which is related to the development of gastric cancer is actually prior gastric surgery. So anybody who's had a gastrojejunostomy, for example, for a peptic ulcer sometime in the past, this is now largely an obsolete operation. We'd hardly do it for peptic ulcer. Or anyone who's had, weight reduction surgery, for gastric surgery, in which it only occurs when you've actually joined the stomach and the intestine together. So the gastric sleeves and all that don't have a risk of developing gastric cancer. But if you've joined the intestine and the stomach together, and so you're getting bile refluxing back into the stomach, then this bile refluxing back into the stomach increases the risk of developing a gastric cancer over a period of time. And they say that it's about a 3 times greater risk compared to normal. And that risk usually starts around 20 years after the surgery. And so they recommend, there is some people who recommend that you should do a check endoscopy on these patients, starting 20 years after their previous operation. But again, there's no standard recommendation. And this can lead to the development of gastric cancer. One which I haven't listed here is gastric ulcer. So you get ulcers in the duodenum, which are the most common, and the next common is gastric ulcer. But gastric ulcers can be malignant, and therefore, if a gastric ulcer is seen, it's very important that the endoscopist takes biopsies from that ulcer, treats, if it comes back benign, you still treat the ulcer with standard medication, and the onus is on the patient and the gastroenterologist to make sure that ulcer heals, because you may have missed the cancer in your initial biopsies. And so you must, for a gastric ulcer, even if the patient, all the symptoms go away, it's important to do a repeat endoscopy after about a month or 6 weeks to make sure that that ulcer has completely healed. Because sometimes the symptoms will go away with medication and you think everything is all right, but actually it was a malignant ulcer, and then symptoms will recur after a little while as the cancer becomes bigger. Now, this is very different from duodenal ulcers, which are the more common type of ulcer, where there is almost, it does not turn into cancer. And therefore, if you see a duodenal ulcer, it's not necessary to take a biopsy. And also, it's quite all right for you to just take the treatment and assume as the symptoms disappear that the ulcer has healed and that it's not cancerous. So the treatment of gastric and duodenal ulcers differs slightly. Other conditions, gastric polyps. So a polyp is a little bump on the surface of the lining of the intestine. And if it is a type of polyp, which is called an adenomatous polyp, then as it enlarges, particularly polyps which become bigger than 1 centimeter, and definitely if they're more than 2 centimeters in size, the risk of transformation to a cancer becomes higher. There's a condition called pernicious anemia. It's less common in our country, much more common in the West. This is an autoimmune condition in which the lower part of the stomach, the lower third of the stomach in particular, becomes very inflamed and atrophic. It's also called atrophic gastritis. So instead of the normal linings of the stomach, it becomes a sort of a flat, effaced kind of a lining. And these patients, this is the part of the stomach which is very important for the absorption of vitamin B12. So if you get pernicious, if you get atrophic gastritis, severe atrophic gastritis or pernicious anemia, then you will also become deficient in B12, because the factor which is required to absorb B12 is no longer being produced in that portion of the stomach. And these patients are at risk of developing cancer. Again, from my memory, when I was treating such patients, I didn't see this all that often. It also, to some extent, may be historical, and it may also be that it's just more common in the West than it is here. Menetrier disease is a very, very rare condition where the lining of the stomach becomes hypertrophied. So instead of, it's the opposite, if you like, of pernicious anemia. Pernicious anemia, the lining becomes almost flat instead of the normal wavy lining of the stomach. Here, those waves become really big and fat and protruding into the lumen of the stomach. And these patients are also at increased risk of cancer. Extremely rare disease. infection with Epstein-Barr virus. Classically, it's associated with nasopharyngeal carcinomas, but there is a slight association with stomach cancer as well. And then there is this immune deficiency, which is an inherited condition, extremely rare, and which is also associated with different types of cancer. Extremely uncommon. So amongst all these, I would say prior gastric surgery is something that you can definitely follow up on. Patients who on endoscopy are noticed to have gastric polyps or a gastric ulcer should also be carefully followed. There are a number of inherited cancer syndromes, and I've just listed them here. I don't know how, it's not something you routinely screen for, but it's very important for one to take a history from the patient, whether any of their family members have also had gastric cancer. So the common ones are, I mean, when I say common, I'm talking about all these together probably constitute 1 to 2% of all the patients with gastric cancer that one sees. So, but it's very important for you to get a family history, because you're not going to do gene analysis on every patient with gastric cancer who comes to you. So there is this form called hereditary diffuse gastric cancer, in which about 70 to 80% of patients are going to develop a gastric cancer if they have this specific CDH1 mutation. And women who develop this type of cancer are also prone to developing a lobular breast cancer as well. Now, you will only really search for this if you find that the family, that somebody else in the family has developed it. It's a very specific type of gastric cancer. That means the cancer is not on the surface of the stomach, or actually the portion of the cancer on the surface of the stomach may be very small. Most of the cancer burrows underneath the lining, the normal stomach lining, and sort of effaces the normal gastric lining. So the cancer is burrowing underneath the surface. And so you may miss it it's easy to miss on a biopsy, and you have to have a high index of suspicion to diagnose this cancer. It has a very poor prognosis. And this is one condition where definitely if you are known to have this, you have to have a serious conversation about having a prophylactic gastrectomy to remove your stomach and reduce the risk of your developing this cancer, because otherwise, by the time it's diagnosed, the diagnosis can be delayed, it can be difficult, and you lose and there's a very high proportion of patients who get the cancer. Lynch syndromes, I'll talk about more when I'm talking about colorectal cancer, because it's primarily a syndrome which involves colorectal cancer, but people who get it can also develop gastric cancer. It's typically associated with genetic defects in the mismatch repair genes. There are totally 6 genes, but these 2 are the most common. And basically our bodies undergo these gene mutations all the time, but we have these mismatch repair genes which identify the mutations and correct them as they occur, so thereby preventing us from developing cancers more frequently. But if you have a gene mutation which involves one of these genes, then they're not able to correct these mutations efficiently, and it increases your risk of developing a cancer. Again, familial adenomatous polyposis. This is a syndrome in which you get polyps throughout the intestinal lining. predominantly affects the colon, but some of these polyps can affect the stomach as well. And so surveillance involves not only the colonic surveillance, but also involves once in 5 years survey. People who have familial adenomatous polyposis should have an upper GI endoscopy at diagnosis. And then depending on the number of polyps in the stomach, they may require to have further endoscopies. If no polyps are seen in the stomach, then you can scope after about 5 years. Otherwise, you have to do more frequent. Gastric and this GAPS, Liefrom-Any syndrome, I had never heard of it until I put down this list. Peutz-Jeghers syndrome is again something not all that uncommon. It's another form of polyposis. Again, predominantly affects the large intestine, but you do get predominantly affects the small intestine and then secondarily the large intestine, but it also involves the duodenum and the stomach and other organs. And it's typically seen in young people who they will have like little moles, little black spots, which you'll see on their lips and on the inside of their mouth. So anybody with a polyposis syndrome, we always take special care to look at the lips and the inside of the mouths to see if there are any black spots there, because that is diagnostic of this Peutz-Jeghers syndrome. I think that's all I have to say about stomach. And then I'll move on to colon after you've asked me what you want.
Right. I wanted to check up this. Normally, H. pylori infection is a waterborne infection most of the time. It is, I mean, I've heard of that. But how does it spread from person to person? I mean, if
I
say
think just I'm not 100% certain of that. I think it's there in our environment. How much it spreads from individual to individual, I'm not sure. I'm not sure that it is that easily transmissible from one person to the other. I think it's just so prevalent in our environment here that you treat it once and within a few months or less than a year's time, if you test again, the patient will have developed another, H. pylori infection. But I am not aware of person-to-person transmission. But I'll have to look that up, I'm afraid. I'm not very sure.
And what about the stomach cancers? I mean, the stomach, not cancers, the ulcers. Normally, spicy food and some of the medicines, the painkillers also.
So there are many different causes for ulcers. You rightly said, I mean, especially, painkillers like Brufen and Vopan and so on. But those are not caused by H. pylori. So H. pylori is just one of the causes. And those obviously do not turn into cancer.
No, I'm talking of the ulcers.
Yeah, the ulcer. They don't,
okay.
The ones which are caused by, these painkillers and all don't turn into cancer.
Okay.
So we're not talking about those. The thing is that when they do an endoscopy, you can find different types of appearances. You can find multiple small superficial ulcers. We call them erosions of the stomach. They're tiny, tiny ulcers, multiple all over the stomach. Now, we're not concerned about cancer in those. But if you do an endoscopy and you find a single ulcer in the stomach, okay, you obviously take a history from the patient, did you take any painkillers and so on. But whether they have or they haven't, if you see a single gastric ulcer, like I said, the recommendation is that you biopsy that ulcer. It's typically called a 4-quadrant biopsy. You take four pieces of tissue from 4 parts of the ulcer. And if the pathologist says that there's no cancer in that, even then, it's very important for you to repeat the endoscopy after treatment to make sure that ulcer is healed. because a gastric ulcer could be, whether it is a gastric benign ulcer which is transforming to a cancer, or whether it was a cancer to begin with, and you saw it at an early stage and thought it was a gastric ulcer. Either way, you have to make sure that that heals completely. The best way you have of being sure that it's not a cancer is to document that it is fully healed, because cancer will not heal. Yeah.
So,
Aruna, can I ask a question?
just 1 second. Nalini, I'll get back to you. So during our hospital visits, we found in the cases of, we recently met a stomach cancer patient where a part of the stomach was removed, but he says that he can eat well and all. But in under what condition is the gastrectomy done where the whole stomach is removed, and what is the quality of life after that?
Yeah, so for gastric cancer and a number of other conditions, we remove part or all of the stomach. So it's a fairly standard operation. Most of the time when you have a gastric cancer, you're able to leave at least a portion of the stomach. So we normally remove somewhere around 75–80% of the stomach and leave a little bit behind as a pouch. But sometimes obviously the priority is removing the whole cancer. So depending on the position of the cancer sometimes and the size of the cancer, you may have to remove the whole of the stomach. So total gastrectomy. So in the beginning, when these patients first start eating, they have, they eat a little bit and they feel very full. And so we always tell them to eat small, frequent meals. Instead of having 3 meals a day, they may have to have 6 or 8 meals in a day to keep up with their nutrition. But slowly what happens is that the bowel, that either the remnant part of the stomach or the small intestine, which you have pulled up there, takes over the function of the stomach, and it dilates and becomes sort of saccular. And so you can, at a time, you're able to eat a more normal volume of food. So that problem goes away usually fairly fast.
After a time.
But yeah, within a few weeks after they've had the surgery. But there are other problems related to quality of life. Most of these patients will lose some weight. They say on average, a patient who's had a total gastrectomy will lose around 8 to 10 kilos compared to their starting weight. Then also remember that iron absorption, vitamin B12 absorption are all related through the need factors from within the stomach. So the likelihood of your developing an anemia in the, after some months after a gastrectomy is very high. And so we always recommend these patients get vitamin B12 injections, and from time to time, they might need iron injections as well to keep up with their, to prevent the anemia. And there are certain syndromes which we call dumping syndromes, which is when you eat, especially if you take a lot of sugar, it suddenly, now there's nothing to regulate the sugar. Normally when you have a stomach, it gets into the stomach and then it's slowly squirted into the intestine. Whereas here, what happens is the whole volume of food just gets dumped into the small intestine in one go. And especially when there's a lot of sugar in the food that you've eaten, it pulls a lot of water in from the circulation into the intestine. And some patients will start feeling dizziness and sweating after they have eaten. Usually, again, this becomes less after a year, but about 1% of patients can have a very, very severe symptom. And so they have to have special dietary advice. They have to lie down after their meals. Again, some patients will get diarrhea after a total gastrectomy, So there are changes, there's no doubt. But by and large, these changes of these symptoms of diarrhea, dumping, etc., are very infrequent, or they're even it may be about less than 10% of patients will have troublesome symptoms from it. But the problems with anemia and the problem with not being able to take a full meal, those are there. But patients adapt to that
Right.
quite well.
Thank you. My last question is that in case of, as a measure to arrest obesity, on some of the very severe cases of diabetic patients, there is a bariatric, you call
Yes.
it, I'm pronouncing it right, surgery.
Yes.
So what is, can it affect, development of cancer at some stage much later?
Certain types of them can. The most commonly done procedure is what we call a sleeve gastrectomy, in which only, just the size of the stomach is reduced and there's no bypass done at all. But in some types of gastric cancer surgery, morbid bariatric surgery, and especially the ones which are done for diabetes and all that, there is a bypass created. And in those patients, they've also been found to develop gastric cancer. It's a very small proportion of them who develop gastric cancer. So, and it as I said, it may take 15, 20 years before any such thing develops. That is one of the things you
regular follow-up, maybe.
Yeah.
Right. Thank you. Nalini, do you have a question to ask?
Oh, this was about bariatric surgery. So I think the question has been because bariatric surgery these days is a very common procedure.
Yeah.
So I just wanted to know whether long term that does develop into cancer.
There's like I said, it's about 2 or 3, it's 20 years later, and it's a very small proportion of patients who develop it. But yeah, it's something that you might have to keep in mind.
Okay, Dr. Sanjay, next on to the colon.
Okay. Last one is colorectal. So here, the most important, probably single most important thing is colonic polyps, because these are very, very common. This is a very common condition. And most of these, you can have polyps for a number of different types of polyps. But if you have adenomatous polyps, which is a specific type seen on biopsy, then these polyps can go on to develop cancer. If you have a polyp which is more than 1 centimeter in size, then you're looking at about a 10% risk. If you have a polyp which is more than 2 centimeters in size, you have a 30 to 50% risk of developing a cancer. And there are different, the shape of the polyp and all that. So whether it is just like a little bump like that, or whether it's looking like a tree, which is called a villus adenoma, that increases the risk. If you have a villus adenoma, you have a higher risk of developing having a cancer within it. So it's very, very important. And this is not at all uncommon for many of us to have a few polyps scattered around in our intestine. And that is why it is recommended in the Caucasian population in the West. They recommend that anybody who is over 50 should have a screening colonoscopy. And if polyps are found, then they have to have a follow-up endoscopy after a year. And if polyps are not found, then usually 3 to 5 years, after 3 to 5 years, they should have the next colonoscopy. In the African-American population, I think the recommendation is at 45 years onwards that you should have screening colonoscopy. Now, it should ideally be done in our country as well, but nobody likes to have a tube shoved up their bottom. And so it's not a very popular test at all. It doesn't get done. But ideally, one should have, at the age of 50, should have a colonoscopy done and then follow it up accordingly. Now, I'm going to come back to the polyposis syndromes after a little while on the next slide. So we'll talk more about polyps, but this is as far as just the isolated polyps are concerned. The second risk factor is inflammatory bowel disease. That means ulcerative colitis or Crohn's disease of the bowel. Such patients are definitely at an increased risk of developing cancer. And the risk of cancer development depends on the extent of involvement of the bowel. Is it the whole of the large intestine, or is it just a portion of the large intestine? And also the severity of the involvement, whether it's, there are lots of deep ulcers or whether it's just a sort of superficial inflammation. If you have anybody along with that, in a patient with inflammatory bowel, you have family history of colonic cancer, then that risk of cancer is increased. And again, if you have on biopsy, any areas of dysplasia, like I mentioned for the esophagus, a similar thing in the bowel, then the risk of cancer is increased. And so there are various screening recommendations, whether you should do it every year or every 3 years or every 5 years. And it depends largely on the extent. So if you have got a first-degree relative who's younger than 50, you have an extensive involvement of the whole of the colon is involved, or you have what is called PSC, we discussed it last time, primary sclerosing cholangitis in association with inflammatory bowel disease, then an annual screening is recommended. If you have a family member who's older than 50 who had a cancer, then you might require it once in 3 years only. And if only a portion of the colon is involved, and it's very mild disease, then once in 5 years may be adequate. And in the past, I know, once you've had chronic ulcerative colitis for more than around 10 years, the likelihood of your requiring some form of surgery, if it's not, particularly if you're having recurrent attacks, is quite high, or not only treat the disease, but also prevent cancer development. Patients who've had radiation therapy to the pelvis, especially women sometimes for one or other reason, have received radiation therapy to the pelvis. That can cause, especially with the older forms of radiation nowadays, with the the SBRT and the CyberKnife and all these very highly focused forms of radiation therapy, the risk is less. But in the older forms of radiation therapy, the rectum especially and parts of the intestine would get hit by the radiation. And these patients are also at increased risk of developing cancer. And it was recommended that one should have screening in such patients. Family history here is very, very important. So if you have a first-degree relative or 2 second-degree relatives who have developed colonic cancer, then again, it's very important for you to undergo regular screening. And it's usually recommended that you should start the screening either 10 years before the youngest relative, the age at which the youngest relative developed the cancer, or age 40, whichever comes earlier. And then you have to have the scopy once every 5 years. Then again, there are a lot of inherited syndromes. I'll just go to FAP first, because this is the one that is more commonly recognized. So these are familial adenomatous polyposis coli. So FAPC is the correct name. These patients start to develop. It's defined by the fact that you have more than 100 polyps in your colon. And these patients usually begin to develop polyps in their teenage years, and very often by the age of, they usually develop a cancer in their 20s, and by the age of 40, all those who are going to all of them have developed a cancer in the polyps. So there are a lot of variants of this syndrome, which have got names like Gardner's syndrome and Turcott syndrome, etc., which are dependent on what other tumors they get along with the polyposis syndrome. But the principle is the same. Primarily, these are patients who will go on to develop colonic cancer. And the recommendation is that if you diagnose this syndrome, then these patients are advised total colectomy, proctocolectomy with a pouch to create a neorectum, or with a permanent ileostomy, depending on what their preference might be. So it's very important. This is what you call a autosomal dominant transmission. So if if any one of the parents has it, the children have a very, very high likelihood of getting polyposis. And so you have to follow up these patients carefully and take a good family history and screen such patients. Peutz-Jeghers syndrome I spoke about earlier. This forms a different FAP is adenomatous polyps. Peutz-Jeghers syndrome is another type of polyp, which is called a haematomatous polyp, and which primarily involves the small intestine, but also the large intestine, and is also associated with breast, ovary, and pancreatic cancers. So here, this is a little more complicated because FAP almost exclusively involves only the large intestine. So by removing the large intestine, you can largely prevent any kind of cancer development in these patients. Some of them will get polyps in the stomach and duodenum, and they are quite easily managed with endoscopy. But Peutz-Jeghers is primarily a disease of the small bowel. And so it's very difficult you can't just go and do surgery and fix it. And so these patients, they have a lot of problems because they keep getting symptoms from their polyps in the intestine, either bleeding or obstruction, or of course, going on to developing cancers. And you can't just surgically remove the whole small and large bowel, obviously. Cystic fibrosis is primarily a disease of the lung, but basically any secretory organ, instead of the normal liquidy secretions, it produces very viscid and thick secretions. Most of these patients would die in their teenage years or as young adults. But now, as they have started with better medical care, growing into adulthood and older age group, people are finding that they are at an increased risk of developing colon cancer, but we still have a lot to learn about colon cancer in such patients. And I'd like to finish by just talking about Lynch syndrome. This is another inherited cancer family syndrome. It's called hereditary non-polyposis coli, so HNPCC. And this syndrome is characterized, like I told you, with that mismatch repair genes not being undergoing a mutation. Now there is a 3-2-1 rule in this thing, and I hope I can remember it. It's basically that if you have you have to have 3 members of your 3 relatives. So that is including yourself. If 3 members of your family have developed cancer of the colon, if it crosses at least 2 generations, so your generation and another, and I've forgotten what the 1 is now. I'll tell you what the 1 is. Anyway, it'll come back to me. So 3-2-1 rule. which helps you to diagnose. Sorry. So you have to have at least one of those relatives has to have developed the cancer before the age of 50. So that's the 3-2-1 rule. 3 members of your family across 2 generations, and at least one person having a cancer diagnosis before the age of 50. Then this is what makes you clinically suspect the likelihood of Lynch syndrome. Typically, these are young patients who develop the cancer. The cancers are more common on the right side of the colon. The lifetime risk is as high as 80%. It varies depending on the penetrance to between 20 to 80%. And you are also at risk, women are at risk for endometrial carcinoma, which is the highest, which is the most common one outside of the colon cancer. But it can involve a large number of different cancers, as I've listed over here. So if you see a patient who you suspect has got Lynch syndrome based on the 3-2-1 rule or the development in the family of these kind of cancers, then you would need to do a check of look for these mismatch repair gene mutations, and these patients need to undergo surveillance from a very young age, from the age of 20 to 25 years onwards. They have to have regular colonoscopies. And even once in 5 years, so a colonoscopy once at least every 1 or 2 years, an upper GI endoscopy at least once in 5 years, because they can also develop, as I said earlier, stomach cancers. And then you treat these patients accordingly. Whether you want to go and do a prophylactic colectomy and all, those are discussions which have to be between the patient and the doctor and have to be individualized. But there's no standard recommendation. And I think, yeah, that's it.
Thank you. Thank you. This is little alarming in the sense that when it is hereditary, the uneducated lot, the ignorant lot, they will not even know that there had been a family history where one of the parents or some relation.
The thing to remember, ma'am, is like Lynch syndrome and these inherited syndromes constitute only about 2% of all patients, even in the West.
Okay.
Constitute only about 2% of all the patients with colonic cancer. So, it's important to recognize these patients, but it's not like, oh gosh, if I miss it, it's going to be the greatest tragedy of all. You're still going to help the vast majority of patients. Yeah.
Okay. Now, we have 2 sort of organs. One is colon and the other one is rectum. So apart from the fact that colon cancer means only in the colon and colorectal means both are involved, that's the basic difference? Or what?
No. So the difference is, the reason why there's a slight difference is that obviously the location of the cancer, if it's, in the rectum, there are a lot of other close organs close by and all the rest of it. But the main difference is in their response to chemotherapy. So rectal cancers, for whatever reason, respond much better to chemotherapy than colon cancers do. So, you can just, I should probably have just kept it as colonic cancer or, colorectal cancer, but it's generally put as colorectal cancers because, rectal cancers are very often treated even before surgery. They get treatment with chemotherapy because they're much more sensitive to chemotherapy than. And it's also much more easier to give them radiation. You can't really give radiation to colonic cancers because there's lots of small bowel and other organs in front of that, and you can't treat it. Whereas the rectum is fixed in position, and so it's easier to treat. So it's usually discussed as a sort of a slightly separate entity, because you have that many more methods of treating these patients effectively.
So that probably also explains that colon being a very big organ in the sense it has many parts, ascending and transverse and descending. And so the cancer, most common location of the cancer is the lower end of the colon or some.
Yeah. So if you
could
take
be any
colon and rectum together,
Mhm.
then rectum constitutes somewhere around 30% of all the cancers. So it is the single most frequently involved site. And then it is followed by the sigmoid colon and the cecum. So the sigmoid and the cecum are the two
lower.
next most common involved.
Right. Then another
Question.
is what is diverticulitis? Am I
Diverticulitis.
Yeah.
This is
So
what
this
Indraji has
again,
asked.
No, I
Yeah.
just wanted to know, are there risk factors if you have a diverticulus?
I don't think so. The risk only occurs that sometimes making the diagnosis can be a little more difficult in patients who have diverticulosis, because there is the whole colon is a little bit distorted, and so you can miss early cancers in that situation. But I don't think diverticulosis per se is a pre-cancerous condition.
Thanks.
I'll come back to you, Dr. Anjali Rao. Give me a minute. Elderly often complain of, sort of not clearing their stomach, bowels in the morning or once a day only. It's because of the low intake of the food or low fiber intake. So they often resort to mild laxative or something. Is there a danger for having any sort of developing into cancer later?
Yeah. So not per se, not because of the constipation, but what they say is that whatever carcinogens are there in the gut, if you have a slow transit time that means you're not opening your bowels normally or as completely as one normally does, then there is a greater risk of contact between the carcinogen and the lining mucosa. So from that angle, there may be a slightly higher risk. And that was one of the theories that was proposed in years gone by. Certainly when I was a student, we were always taught that colonic cancer is much less prevalent in India than it is in the West, which I don't think is true anymore, but that's what they used to say. And one of the reasons that was always given was that our diet had a lot more roughage in it. And so we had a lot less constipated people. But again, I don't think that's true either anymore.
And what are the basic, if polyps is such a danger for risk for this cancer, colorectal or other gastric cancer? So what are the symptoms of one would know that they have polyps?
That's the whole reason that you don't get symptoms. Because they're so small. I mean, if you have a 1 centimeter little bump in your colon somewhere, you're never going to know. So that's why screening is so important in
so why not India permit at least
permit.
I'm not saying that there should be any law for that we must do it as it in the West, but I know from my own experience that when I went to a gastroenterologist, I had to really convince him and take another doctor with me whom I knew that please allow me to have colonoscopy done, because I've had maybe for my little knowledge of cancer or whatever. So with great difficulty, he's wrote the prescription that yes, and he kept on saying, no, ma'am, you don't need it, you don't need it. So at least if one is ready to do it, why not?
I don't know. It's usually patients are complaining the other thing that they did a whole lot of unnecessary tests on me. So I don't know why this guy was being so particular about not doing it. But you're right that many doctors don't advise patients to have the screening colonoscopy. And for example, I have certainly not had a screening colonoscopy, and I have no intention of going there to anyone to
Well,
have it done.
you know it so well that
But
you know.
yeah, it should be done ideally, yes.
Yeah. Dr. Anjali Rao, would you like to ask? I see some hand being raised.
Yes,
Yeah.
thank you, Aruna.
Hello.
Thank you very much. Thank you very much, Dr. Govil, for a really extensive coverage of all those cancers. And not only that, you have raised so much interest and raised questions, discerning questions from the people who are listening. And that, I think, is the success of your talk. From speaking from ICS point of view, where we are doing HPV test, DNA test, we are doing it for cervical cancer. So we've attended a lot of lectures, and in that, anal verge cancer is one of the things for which HPV testing is, HPV positivity is there. Have you actually seen cases of anal verge cancers which are HPV positive, and also whether the anal tags and the anal
It's not anal tags, ma'am. They get anal warts.
Warts, yes.
So you get that typical, warty kind of tumor. And within that, they will turn into a cancer. Probably the most famous person to have had this is Farrah Fawcett Majors. So, she was a pin-up in the 70s, I think, and a very good actress. She unfortunately died of this, but yes, I have seen, as I said, I haven't been involved in treating colorectal cancers for about 20 years now, but I remember a number of patients. It's not uncommon.
No, I'm not talking about colorectal.
No, I know. I'm talking about anal verge. So anal verge cancers, cancer of the anus, So that is definitely associated with HPV.
Yes. Continuing on that, should we not recommend the vaccine to this special group now, which is more and more likely to come out, from the transgenders, from the gay community? Should it not be a strong recommendation from the medical community to undergo HPV vaccination? Because there's no such recommendation currently. So
I think you're probably right. To me, it sounds very sensible, but I think there must be some kind of data from somewhere around as to what the actual incidence of this tumor is and what the efficacy of the vaccine is in preventing it. I don't know enough to be able to say, because there's no doubt that HPV is related to anal verge cancers, and there is a high-risk population as you have described. But there are a lot of other, factors which come into whether it's worth doing a screening, whether it's worth vaccinating these patients in terms of the frequency of these cancers, how often they've isolated HPV, the efficacy of the vaccine. I don't know enough about it to be able to say anything, but I think it's definitely something worth looking up, because I can clearly remember a number of patients who had these kind of problems.
The thing is, they have a very strong voice in the community, especially in the West.
Yes.
So, and they recommend the monovalent vaccine, HPV vaccine, Gardasil 9 for this. So I feel from the doctors' community, especially that since this population is fairly high in India, a recommendation may be made, because they look after their own and they'll ensure that community will be protected.
Yeah. So is it a recommendation in the West as yet?
I have not seen it. That's why I said
from the I'm not sure why it isn't.
Not yet recommended.
Yeah. So I'm not sure why it isn't. I don't know enough about the vaccine, but from what I remember, the one which is most associated with cancer, the virus is number 16. Is that right?
18. 16 and 18.
16 and 18.
So that is covered by the vaccine, is it?
No, not
Yeah,
for this
yeah.
one, it is the nonavalent which is required. Gardasil 9 is required for anal verge cancer prevention.
16 and 18 are for cervical,
Well,
but the rest of them are for the warts and the
So,
other six.
so I think, you know, it's, to me, it sounds very sensible, but as I said, it's not an area that I'm particularly involved in, on my day-to-day work. So I'll have to look it up, but it sounds very reasonable what you've said.
I
Thank you,
only
Dr.
also
Sanjay.
mentioned it because you would do so many colonoscopies, you're likely to see more cases. That's all.
No. I'm an HPB surgeon. I do liver and pancreas.
Mainly liver
So that's why
transplant.
I'm not
even.
involved in this side of things. But I'll certainly ask my colleagues and find out whether there's any recommendation of the sort. I didn't see anything of the sort, but nor did I specifically look for it. So I'll check.
Thank you very
Thank you,
much.
Dr. Sanjay. If you, stop sharing your screen, then we can have the audience
Okay.
and I can request Dr. Colonel Tomar to propose the vote of thanks. Colonel Tomar, are you there?
Yes, ma'am.
Yeah,
Thank
please
you.
do the honors.
Thank you, Dr. Sanjay.
Thanking Dr. Sanjay.
Taking
Some
the message.
brilliant talk, man,
Thank
Dr.
you.
Sanjay.
Thank
It was
you.
absolutely fine and very educative. And we
Thank
would like to thank you for all the education you have imparted to us. Thank you, Dr. Sanjay.
Thank you very much.
Thank you very much for your time,
Thank
really.
you. Bye-bye.
Bye.
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 Bye, Ma.
Thank you, Jyotsna, to you.